surgery initiative.
Welcome to today's episode. We're diving into a detailed, complex medical case reconstructed by the Texas Medical Board. It's a raw, worst-case factual report about a cervical spine surgery with multiple operations and serious complications. Chloe, this one really strips away any institutional spin and just lays out the facts, contradictions, and clinical consequences.
Absolutely, Liam. It's a sobering look at how diagnostic errors and documentation inconsistencies can seriously impact patient outcomes. The patient, Lowell Unruh, underwent several surgeries between mid-October and early November 2024. The report is exhaustive and intentionally free of any mitigation language, which makes it a valuable case study.
Let's start with the surgical timeline. On October 14, 2024, Mr. Unruh had a C3 to C5 anterior cervical discectomy infusion, or ACDF.
For those listening, that's a common procedure where damaged discs in the cervical spine are removed and the vertebrae fused to stabilize the neck.
Right. Then, just a few days later, on October 17th, he had wound exploration and seroma evacuation. A seroma is basically a fluid collection that can happen after surgery.
Then on October 21st, things escalated. He underwent a C4 corpectomy with anterior cervical corpectomy infusion, or ACCF. That's a more extensive surgery involving removal of the vertebral body itself, which indicates severe pathology.
Exactly. By October 21st, the pathology was bad enough to require vertebral body removal, a salvage-level intervention. Then on October 24th, he was transferred to University Hospital, and the next day, October 25th, he had a repeat anterior cervical surgery performed by Dr. Christopher Chaput.
Now, here's where it gets really interesting. The sole preoperative diagnosis for that October 25th surgery was a cerebrospinal fluid leak, or CSF leak.
Just to clarify, a CSF leak is a serious complication where the fluid surrounding the brain and spinal cord escapes, risking infection and neurological damage.
Exactly. This diagnosis justified repeat surgery, lumbar drain placement, and extensive re-exploration.
But here's the twist. Dr. Chaput's operative note explicitly states no active CSF leak was found during surgery.
Instead, they discovered a 2-centimeter vertical laceration of the cervical esophagus, which required management by ENT specialists.
So, the surgery was planned and justified for a CSF leak that wasn't actually present, while the real injury was an esophageal laceration that hadn't been diagnosed preoperatively.
That's a huge discrepancy. It's a classic example of diagnostic anchoring, clinicians fixating on one diagnosis and overlooking others.
But it gets more complicated when you look at the documentation contradictions highlighted in the report.
Right. The operative record contains mutually incompatible elements. For example, the pre-op diagnosis was a CSF leak, but intra-op findings showed no CSF leak.
Post-op diagnoses list both SAMUS pre-op and the esophageal laceration.
And the wound was classified as Class 1, meaning clean, which contradicts the presence of an esophageal injury that carries infection risk.
Yet, they collected deep cervical space cultures and administered broad-spectrum antibiotics like vancomycin and zosyn, which are typically used for serious infections.
These contradictions can't logically coexist in a coherent clinical narrative. It suggests a failure to reconcile findings in the medical record, which can have serious implications for patient care and legal accountability.
Exactly, and the post-operative course confirms the severity of the esophageal injury.
After the October 25th surgery, the patient remained intubated until October 28th, was kept NPO, nothing by mouth, for 7 days to protect the esophagus, required ICU-level care, had a Penrose drain placed to manage fluid collections, and showed aspiration on swallow study, indicating swallowing dysfunction and risk of pneumonia.
Plus, he was discharged with plans for prolonged intravenous antibiotic therapy. All these details confirm the clinical consequences of the esophageal injury. It wasn't a minor complication.
The report's worst-case interpretation is that the esophageal injury likely occurred earlier in the surgical course but went unrecognized.
This allowed infection and instability to develop. Meanwhile, diagnostic anchoring on the presumed CSF leak drove escalation of care, including vertebral body removal, despite no objective confirmation of the leak.
Only during the repeat surgery was the true pathology, the esophageal laceration identified.
This really highlights the dangers of diagnostic anchoring bias. It's like a detective who locks onto one suspect and ignores other clues, leading to a wrongful conclusion and missing the real culprit.
That's a great analogy. And the core factual conclusion is clear. A major esophageal injury existed by October 25th. The surgery aimed at treating a CSF leak did not find such a leak, and documentation was not updated to reflect these findings.
This represents a failure of diagnostic recognition and documentation accuracy.
The clinical consequences were significant: prolonged ICU care, aspiration risk, and extended antibiotic therapy.
It's a cautionary tale about the importance of revisiting diagnoses when intraoperative findings contradict pre-op assumptions.
And it underscores the need for accurate, consistent documentation for patient safety, continuity of care, and medico-legal clarity.
Also, multidisciplinary collaboration is critical. ENT involvement only happened after the esophageal injury was found.
Absolutely. For our listeners, especially those involved in surgical care or clinical documentation, this case is a reminder to stay vigilant against cognitive biases and to ensure that medical records reflect the true clinical picture.
To sum up, this report strips away any mitigating language and forces a clear-eyed look at what happened.
Diagnostic anchoring led to escalation of invasive procedures without confirming the underlying pathology, and the missed esophageal injury had material clinical consequences.
Thanks for joining us for this deep dive. We hope this case encourages reflection on how diagnostic errors and documentation inconsistencies can be prevented in clinical practice.
Until next time.